Good morning, students. I'll be going to talk about medical emergencies in dental practice. I'm Dr. Vikas, Prof and HOD, Oral and Maxillofacial Surgery. So the contents of the topic are common medical emergencies, antibiotic prophylaxis, American Society of Anesthetists, physical status classification, stress reduction protocols, contents of emergency kit, important point about vital signs, unconsciousness, differential diagnosis, hemorrhage, respiratory distress and differential diagnosis. So what are the common medical emergencies in dental practice? You have unconsciousness, altered consciousness, respiratory distress, seizures, drug related emergencies and chest pain. So the unconsciousness covers vasopressor, syncope, orthostatic hypotension, acute adrenal insufficiency. Altered consciousness deals with endocrine disorders like diabetes mellitus, hyper and hypoglycemia, thyroid gland dysfunction and cerebrovascular accident. Respiratory distress, you have airway obstruction, hyperventilation, asthma, heart failure and acute pulmonary edema. And seizure related drug emergencies, you have drug overdose reactions, allergy, chest pain, you have angina pectoris, myocardial infarction and sudden cardiac arrest. So this is about antibiotic prophylaxis, the endocarditis where prophylaxis is recommended, the procedures which can be performed. So the common prophylactic regimen standard is amoxicillin. Adults are 2 grams and children 50 mg per kg orally, 1 hour before the procedure. If you can give it IV to 30 minutes before the procedure. If the patient is allergic to penicillin, then preferably you can use for adults clindamycin 600 mg or for children 20 mg per kg orally 1 hour before the procedure, or cefalexin or cefadroxil 2 grams for adults and children 50 mg per orally. So American Society ASA classification, you have ASA type 1 means a patient who is normally healthy patient. ASA type 2 is a patient with mild systemic disease. ASA 3 is a patient with severe systemic disease which is not incapacitating, and ASA 4 is where a patient is having a incapacitating systemic disease, and ASA 5 is a moribund patient. ASA is emergency operation of any variety. So coming to stress reduction protocols, it is it can be utilized in any of the anxious patients. You recognize the patient's level of anxiety, pre-medicate evening before the patient comes to the department, pre-medicate immediately before the dental appointment if needed, schedule the appointment accordingly. Mostly morning is preferable, minimize patient's waiting time, otherwise anxiety increases. Consider psychosedation during therapy, adequate pain control during therapy, and length of appointment should not be variable. Medical risk patients are ASA type 2, 3, 4. How to manage them? One is recognize the patient's medical risk based on the case history which you take thoroughly. If there is a medical consultation required, please refer the patient before the therapy. Schedule the patient's appointment in the morning. Consider psychosocial, all the stress reduction protocols. And please follow up in the evening if you have done any procedure. So what does the emergency kit contain? So emergency kits are divided into 3 modules. Module 1 is essential emergency drug. For allergy you have epinephrine and the availability is 1:1000 mg per ml. Allergy histamine blocker, chlorpheniramine, diphenhydramine. Non-injectables you have oxygen. Vasodilator, that is nitroglycerin, it is a nitrostat sublingual tablet, 0.4 mg in meter doses. Bronchodilator, you have albuterol. Metoprolol is an alternative. Antihypoglycemic sugar, an alternative is a juice or a soft drink. Or inhibitors of platelet aggregation, you have aspirin, which are a blood thinners, 325 mg per tablet. Equipment in module 1, we have oxygen delivery system, automated electronic defibrillator for cardiac arrest, or syringes for drug administration, suction and high volume suction, tourniquets, and McGill's intubation forceps to retrieve any foreign object in the oral cavity in case of emergency. So module 2, you have secondary non-critical drugs. What are they? In anticonvulsant category, we have midazolam, alternative is diazepam, and the dosage is 5 mg per ml. Analgesic, you have morphine sulfate, meperidine is an alternative, and 10 mg per ml. Vasopressor, you have phenylephrine, 10 mg per ml, and antihypoglycemic 50% dextrose, alternative is glucagon. It takes a little longer time to act. It's 50 ml per ampule. Corticosteroid, you have hydrocortisone, alternative is dexamethasone, it's a long acting. Hydrocort is short, and I had antihypertensive, you have esmolol, propranolol, 100 mg per ml is the dosage. Anticholinergics, you have atropine, alternative scopolamine, the dosage is 0.5 mg per ml. Non-injectables, you have respiratory stimulants in module 2, like aromatic ammonia, and antihypertensive like nifedipine. So module 3 drugs, advanced cardiac life support drugs. You have, for cardiac arrest, you have epinephrine, alternative is adrenaline, dosage is 1:10,000, 1 mg per ml. Analgesic is morphine sulfate, alternatives is nitrous oxide oxygen, 10 mg per ml is the for morphine sulfate. Antidysarrhythmic, you have lidocaine, prosinamide is the alternative, 100 mg per syringe. Symptomatic bradycardia, the drug of choice is atropine, alternative is isopretinerol, and the dosage for atropine 0.1 ml, 1 mg per ml. Paroxysmal. So coming to unconsciousness, there are two types of stress presentations. You have vasodipressor syncope, hypoglycemia, epilepsy, myocardial infarction, cerebrovascular accidents, adrenal insufficiency. Stress absent is there in postural hypotension, ingestion of drugs, allergic reactions, and hyperglycemic reactions. So position the patient at the time of syncope. If it is upright, you most probably have a vasodepressor syncope or hyperventilation, unlikely. In supine to upright, if a patient gets a syncope, it is postural hypotension. In supine, if a patient has syncope, it most commonly drug-related emergencies or seizures, hypoglycemia, and cardiovascular disease. So based on the age of the patient, what commonly causes unconsciousness? Child, commonly hypoglycemia, epilepsy, or congenital CHDs, congenital heart diseases. Teen to mid-30s, it can be psychogenic, that is vasovagal. It can be hypoglycemia or epilepsy, and more than 40 years is mostly likely cardiac event. So differential diagnosis, you have no clinical symptoms, then postural hypertension, if the episode occurs immediately after change in position. Pallor and cold clammy skin commonly seen in case of syncope. Tingling and numbness commonly seen in hyperventilation cases. Headache, it is commonly seen in cerebrovascular accident, hemorrhagic events. Chest pain, you'll have in angina pectoris, myocardial infarction, rarely in cases of hyperventilation. And breath odor, if it's sweet, fruity, then it's most likely a patient of hypoglycemia or ketoacidosis. And tonic-clonic movements and incontinence you see in epilepsy. So in most of the hypoglycemia and hyperglycemia, the blood pressure, heart rate and blood pressure rise. Heart rate rises, blood pressure drops. In vasodepressor syncope, heart rate also drops and blood pressure drops. And in postural hypertension, only blood pressure drops, and cerebrovascular accident, heart rate is variable and blood pressure increases. So duration, if it is short unconsciousness, it most likely it's a postural hypotension or a vasodepressor syncope or a cardiac dysarrhythmia. Prolonged, it might be hypoglycemia, hyperglycemia, adrenal insufficiency, and cardiac dysarrhythmias. So what exactly we have to do if a patient has unconsciousness? Supine the patient, call for help, immediately activate EMS system, emergency medical system, call for an ambulance. Airway maintenance, head tilt, check airway, breathing, chin lift, jaw thrust procedure. If there is a recovery, then it's most likely a vasodepressor syncope. If dizziness is there in upright position, it's mostly a postural hypotension. If unconsciousness persists, then try to maintain airway, breathing, ABCs, check circulation, carotid pulse. If it's present, then it can be a case of adrenal insufficiency, administer cortisone. If it is a diabetes mellitus, inject 50% glucose IV or glucagon IM. If it's negative and patient still not responding, then you have to immediately shift him to the nearby hospital. Recovery, if there is a recovery, then it is a most likely hypoglycemia. No recovery, then it is non-related diabetic. And if carotid pulse is absent, activate EMS system and initiate CPR immediately. Thank you. I'll continue in the next class. Thanks a lot.